Well, hi, good morning, everyone. Thank you very much indeed for joining us. And I'm going to start off right away with the presentation so that we can work our way through. So let's just load up my slides if you can, please, Rob. Thank you very much. And you can see the panel there in the corner as well. So good morning, welcome everyone. Welcome to this webinar hosted by GovConnect and Clinic Healthcare Solutions. Today, we will discuss the use of artificial intelligence in healthcare delivery. So this webinar aims to show clinicians how we can ensure we see the right patient at the right time through efficient redirection into relevant healthcare pathways. Now, importantly, who's who here today? Starting off with some introductions. I'm Dr. Nick Haywards, and I'm an academic clinician. I'm currently researching neuroimaging techniques at Aalto University in Finland. But also, I have many years of experience in the NHS within critical care and anaesthetics. As well, I'm a UK medical advisor to Clinic Healthcare Solutions. Now, I have to say, we're absolutely thrilled to have 3 exceptional guest speakers today, and 4, in fact, we've had an extra join us too. Firstly, Dr. Indra is an emergency medic with much experience in healthcare policy as a SAGE advisor, a World Health Organization advisor, and most importantly, she's now Director of Artificial Intelligence with NHS AI, managing the future of healthcare delivery. Next, we will welcome Dr. Kanesh Rajani and his colleague, Samson Djibouti. Kanesh is a GP partner in Harrow, and he's chair of Harrow Health CIC, the GP Federation in Harrow. Kanesh also has much experience in educating GPs and previous experience of commissioning as a clinical commissioning group clinical director. As mentioned, he's joined today by Samson Djibouti, who's head of primary care at Harrow Health. And then our final talk will gladly come from Dr. Thomas Patel Campbell, a GP partner at the Haxby Group, which is a super practice at the Humber Coast and Vale. Thomas is also the Haxby Chief Clinical Information Officer. So briefly, the agenda for today, hopefully you've seen this already. It includes my introduction here and then followed by Indra's presentation from an NHS AI perspective. Then Kanesh and Thomas will share their expertise of AI in healthcare delivery from Harrow and from the Humber region as well. We will then enjoy a group discussion with you and the panel, so do please share your comments, your questions, your thoughts, or any ideas at all really in the group chat window. We've got some moderators managing that. So, what is Clinic and who are Clinic Healthcare Solutions? Well, the purpose that we've defined for ourselves is that we want to help healthcare providers to cope with the increasing demand with the same or fewer resources in a less stressful way. And actually, it's Clinic's AI-based triage system and patient flow solution that aims to optimize general practice and urgent care capacity. We improve patient access and aim to bring together local primary care services. So how do we do that? Well, we've been doing this since 2013, and we were built by a core team of doctors and engineers in Finland with expertise on how patient pathways should be arranged for high quality care and cost effectiveness. Our intelligent AI triage and patient flow management solution now has a presence in the UK, Portugal, Finland, and the Netherlands. Now, in Finland, it's fair to say that the integrated primary care centres were facing challenges that are very similar to the UK NHS, seeing increasing demand, a shortage of general practitioners, and a need for patient flow management systems. And these Finnish healthcare centres formed really the best learning environment for us here at Clinic, because it enabled us to develop a wide diagnostic range because of the broad offering of primary care services in Finland. So, with that said, we currently have a product that, based in the UK and Finland combined, is operational at over 500 healthcare centres with a user base of more than 2.4 million patients. In the UK NHS specifically, more than 100 GP practices have joined us, and we have approximately 1 million patients that we take care of. So this is our take on the traditional GP practice setting without an intelligent patient flow management solution. This traditional method is something I'm sure you're familiar with. So patients with a variety of different needs either call the practice or submit an inquiry via an online form. This creates long queues on the phone lines and within the online systems. So the incoming inquiries are effectively one big flow, and the practice staff really don't have much insight into the urgency or the clinical priorities. And the back-end systems don't allow for prioritization of incoming inquiries or efficient redirection within the practice. This makes it difficult to determine the right clinical pathway and the best course of action for each patient. And ultimately, appointments are often booked according to demand and not according to clinical need. Data collection can be inconsistent, and resource allocation may be inappropriate, which leads to a poor patient experience. So with Clinic, our goal is that we want to put clinicians and staff in control of patient flow. And I'll go through this slide in steps here. There are 4 key steps from left to right. So starting with the elements here on the left, firstly, we have an intuitive total triage platform that handles clinical and non-clinical inquiries coming through the internet or from phone calls and walk-ins as well. We provide an online platform for patients to submit their inquiry succinctly. But for patients that cannot or do not want to submit their inquiry online, we provide a telephone module for the care navigation team to take the same inquiry through the same system. Then, next, we create a customized workflow for the different types of inquiries that can be directly linked to the relevant team or resource within the general practice. The medical inquiries will go through our AI algorithm, which automatically recognizes over 1,000 symptoms and conditions. Some of these will be emergencies, or conditions will be recognized for self-care, but also conditions that can go straight through to the physio or mental health professionals or the community pharmacy are beginning to be redirected accordingly. This is currently a decision support tool for clinicians who within the practice will oversee the process, which leads me to part 3 there. The information coming from our AI engine is presented in the practice interface, and there the staff can use our patient flow management system to efficiently collaborate and redirect patients prior to them ever needing to see the GP. And then finally, the BI system is mentioned there. We provide comprehensive dashboards that present all inbound data, including the frequency, incidence, and prevalence metrics for different conditions and different demographics. So that's briefly what Clinic Healthcare Solutions can provide, and hopefully introduces some of the concepts for today. And let's move forward with some themes for this webinar as well. What could the future of healthcare look like in terms of functionality using AI? So we're curious to learn of the healthcare needs where you as the audience might think that artificial intelligence could help. And I'm sure the presentations today will help to address these themes. Next, what are the opportunities and barriers to adoption? So personally, I'm very concerned around the safety of artificial intelligence and ethics as well. And those will be some of our main priorities, of course. Finally, what are the important elements to consider regarding patient perspectives and user experiences or needs, including staff needs as well? Of course, we're asking that question, who are the key stakeholders and how do we engage with them to improve the healthcare pathways with artificial intelligence? So thank you very much once again for joining us today. Chris, one of our directors, is open to your contact and he's actually hidden within the webinar chat here with us too. So please do contact him right there in the chat. You can also request a demo with Chris via a link that will be shared there on this webinar as well. So please do keep your questions and comments coming via that chat window. We're going to be launching 2 audience polls as well, so you can interact with us and share your thoughts. Please do share your feedback with us. The first poll will go live in just a moment. It's a simple check there in the webinar. I see that's come up. That's great. And I thank you very much for your attention once again. So as per the agenda, I'm glad now to introduce once again Dr. Indra Joshi, Director of AI at NHS. Indra, please do share your presentation with us. Thank you very much.
Brilliant. Thanks, Nick. And morning, everyone. Great. Here we go. Slides are up. So I'm just going to give a really brief overview. It's a real whistle-stop tour through what we're doing in the NHS AI Lab. So we're a £250 million programme set up a year ago, really to accelerate that safe adoption of AI into health and care. I'll give you an overview of the programs that we've done and some of the content that we've produced. And if you do want to know a bit more about some of the technologies or understand a bit more, a lot of content is there on our website, which we'll put up right at the end. So for those of you who aren't aware, NHSX, we're a joint unit between the Department of Health here in England and NHS England and Improvement. So we really blend of both policy and delivery, as well as having some procurement routes. In the NHS AI Lab, so just an overview, we quite often talk about the potential of AI to improve health and care. We've just broken it down here a little bit. I won't read through the slides. Do take a look, and the slides are going to be there afterwards for you to have a look too. But really to say, well, it's a broad range of topics, AI. And actually here are just some of the key programming methodologies that really help in the different ways. And Nick talked a little bit about decision support as well. So essentially, the NHS AI Lab, we're 5 delivery programs: regulations, ethics, skunkworks, imaging, and many of you may be familiar with our AI and Health and Care Awards. But underpinning that, we really are about strategy and policy. We do a lot of collaboration and engagement. And then obviously as a massive program, we do have a program management team. So I'll just go through each slide just to give an overview. So one of the things we're very conscious of, it's great to talk about technology. People love talking about the actual nuts and bolts of we're making this model or we've deployed this. But underpinning that is really making sure that the regulation system works for that forthcoming technology. And so we work with all of our regulators here in England. We have the MHRA, many of you will be familiar with them, the CQC, the Quality Care Commission, which really looks at services, HRA, the Health Research Authority, as well as our Clinical Excellence Department, NICE, the National Institute of Clinical Excellence. And so we have a number of programs there, which is really about driving forward the clarity of the regulation needed for the particular product, understanding what happens once it's deployed, so that evaluation, both clinical or non-clinical, and then understanding what happens in that what we call post-market surveillance. Moving on, Nick talked a little bit about ethics being incredibly important. I concur as well. What we've seen a lot over the recent years is an introduction of more and more bias as people develop algorithms. And so one of the things we're quite conscious of is really addressing that right from the root. And so we're not doing this by ourselves. We're partnering up with a number of fantastic organisations as outlined here, the Health Foundation, Wellcome Trust and Health Education England, as well as with the Ada Lovelace Institute to really understand about what we call algorithmic impact assessment. So once something is deployed, what is the impact of that algorithm there? So really trying to understand, for those of you who are interested in this, we have a current call out already. Do take a look at our website. The information is there if you're looking at really, if you're an academic or a researcher looking at forwarding this. I then talked a little bit about skunkworks. So we've just gone through our second round of what we call a Dragon's Den. And this is really flipping AI on its head. So quite often people want to come to us with technologies, brilliant, but we want to work with a system to understand what are the problems that they have. And then can we actually understand whether AI might help solve that problem or whether it needs a different solution. So we've got quite a small iterative team who work out, comprised of data scientists, technologists, as well as policy officials, to really understand what's the problem and how can we then help you solve it. So again, we've just had a round of Dragon's Den. If you're in the system and really want to have apply, we've got a next round coming up over the next few weeks. Then just very briefly, it's always interesting to talk about AI very broadly, but one of the things we've understood, especially over the last year with the pandemic, is we do have to narrow it down sometimes when we talk about a national approach. And so last year at the back of the pandemic, we had a number of companies who said to us, look, we've got great models, great algorithms that can help you with either COVID detection or understanding anomalies in those images. And so we set up something called a COVID chest image database. And on the back of that, we're now working alongside multiple partners to understand, well, what's next in this imaging space? Can we create what we call a national imaging initiative, bringing together those different centres of excellence that are funded as well through UKRI to create a much more cohesive landscape? And then lastly, lots of you will be familiar, as I mentioned, this is our AI in Health and Care Awards. So it goes from different phases 1 to 4. 1 is that very early stage, understanding a proof of concept, all the way to phase 4 if you're a deployed technology or you've been validated elsewhere, validated by regulation, then can you scale up here in the UK? So again, lots of information on the website. And just a little bit of content very briefly on the knowledge hub of what we've got here on the NHS AI Lab. We're very aware that this is a complex landscape, lots of different players, and so we like to put out content quite a bit. Last year, we published a report with the GDHP, the Global Digital Health Partnership, about how to create an international approach. Lots of learning from there. We're taking some of that work forward with the WHO as well as the GDHP. On the flip side, last year, really a lot of people came to us and said, we've got, again, lots of solutions. Can you help us really understanding whether those solutions are good for us? And so again, just thinking about how to create more intelligent procurers. We published this buyer's guide, lots of great content in there. And on the flip side, if you're developing a technology and really want to know how to work with the NHS or the broader health and care system, we've updated what we published previously, a code of conduct to become a guide to good, which has outlined all the different standards, the regulations, the different pathways that you can go down. So that is, in a nutshell, the NHS AI Lab and a broad range of work that we do. If you're interested, do have a look on our website. We've also got a platform on NHS Futures, where again, you can come and join and be a bit more part of the conversation. So I'll stop there. Over to you, Nick.
Indra, thank you so very much for this overview. What a wonderful set of opportunities there. It's fantastic to hear about those activities. Thank you very much for sharing. So next up, we have Dr. Kanesh Rajani and Samson Djibouti with their presentation, and I'll hand over to those guys now. Thank you very much.
Thank you. So as a GP Federation in Harrow, we've coordinated the implementation of the clinic system into 21 of our practices. And so I'm going to share our experience of what that involves. So we've been going for over a year now, and we've implemented total triage into our practices using the intelligent patient flow that clinic gives us, and then using the resources that we have in a multi-skilled, multi-professional team within primary care. And we'll talk a bit about where we think the future might be for us as well. So with total triage, what we aim to do is every patient contact is triaged by the AI system. Traditionally, patients would phone the surgery and book into a doctor's slot or a nurse appointment or any appointment that the patient chose. And often that wasn't the right sort of appointment that they should actually have fitted into for their problem. The aim of this is to make sure that every problem is triaged effectively so that the right person provides the right care to the right patient at the right time. And the clinic system actually risk stratifies each patient problem into an urgent, non-urgent or emergency problem using a traffic light system. So it gives you a red, amber and green classification. And our trained triagers will then triage that patient problem into the right care pathway. The system also gives you an indicative differential diagnosis so that can aid the triager into making sure that the doctor or the nurse that's seeing the patient or the problem has the right skills in order to manage that query. So the beauty of the system is that it's not purely AI driven in that the AI gives you a decision, but the triager can use the knowledge they have of the practice, the local care, in order to either agree with that decision or to modify it in a certain way, so that the system might say that this problem can be dealt with by a nurse, whereas you might not have that particular facility there, and you might be able to then divert that to another care pathway. So there's still human decision making involved, but you're using the skills of the AI. So you've got a good hybrid, which I think is the way, certainly at the moment, until the AI is better developed in order to make automated systems. We can talk about that a little bit later. What the system also does is gives you an audit trail. and a governance so that you know that the problem is being dealt with effectively, so that no query is actually missed. And then whilst these queries are being sorted and seen, there's background analysis that the computer system is doing so that you get a full data set of how many queries came in, what type of queries they are, what symptoms they presented with, what diagnosis the AI came out with, where the problem was rooted. And that's been invaluable in for us to be able to plan our workforce. So using the data sets, we've actually employed clinical pharmacists, looked at the type of physiotherapists we might need in the practice and other healthcare professionals that are actually more suited to doing a lot of the work and seeing the queries that are coming through, rather than the traditional model of everything goes to the GP. And we'll talk about the planning a little bit later. So, as I said, Clinic uses an AI algorithm, which others can tell you more about, but it offers a differential diagnosis based on the symptoms and severity. So the patient will go onto the platform on the patient interface, and they will key in the symptoms that they have, and give a little bit of narrative and free text as well. And then the system will analyze that symptom tree and produce a differential diagnosis with a red, amber, or green flag. And then that query will come through to the back end where the practice can triage the problem. Now, this way, every single patient problem is captured and dealt with, and we aim to deal with each issue within 24 hours, certainly. But in practice, certainly in my practice, within half an hour, each patient query is triaged. So, as I said, the triager has the opportunity to make the final decision, depending on the resources available. So, as I said, it's the right care for the right patient at the right time, using the resources that we have. So, I'll hand over to Samson.
Yes, I just want to talk about our experience in Harrow with regards to the patients as well as the practice staff who have been using AI for triaging. In Harrow Health, we wanted to make sure that we had the perspective of both patients and clinical staff. At the moment, as Dr. Rajani has said, we have 21 practices out of 33 in Harrow using AI triaging. That's a registered patient list size of 170,000. And in the last 1 year, we had 170,000 cases that were dealt with in Harrow, and we're in the second year now of using AI triaging. The next slide here, you will see that one of the beautiful things about the AI system we're using with Clinic is that we're able to look at the top conditions and symptoms. And as Dr. Rajani has said, this will help us with effective resource management, because if we know that there are certain conditions that are topmost in a practice, in a PCN, or in a service, then we can use that to be able to proactively make sure that we have the right resources in place, the right professionals in place. Also below, you see that we have the top 10 symptoms also there. So this has been very, very useful for us in Harrow, and it's helped us to be more strategic in terms of delivery of healthcare. On the next slide, you would see that you have the resource count. Now, what that simply means is through the AI, we're able to see which resource or what resource was actually used for each query. At the moment, we see that figure there is about 60% goes to the GP and 40% goes to other practice staff, and which once again is very helpful for us to know where do we channel our resources most effectively to deal with the cases coming in. The next slide here, this is really something beautiful, and I'm really happy about that we did in Harrow. We said we want to know the patient's perspective. It's good to have these things, but we don't just want it to be abstract. Let's have a feel of what the patients feel about AI consultation form. So we had a very robust feedback of 500 plus patients who came back to us, and 90% found the AI triage information very useful in helping consultation. 80% was satisfied or very satisfied with the outcome, and 81% gave the platform a rating of 7 to 10. This gave us some kind of confidence and say where we are actually moving in the right direction. If the patients, and we were a bit surprised because in Harrow we have an elderly population, and we were surprised that quite a number of them find it very easy to use the system, which was a plus. We also did a survey from the practice staff so that we can see what's going on at the other end. So out of the 21 practices, 20 did participate, and 90% of practices found the triage information helpful in helping the patient consultation. And 80%, as you can see there, found the clinic dashboard helpful, and 70% found it easy to allocate the appropriate patient to the appropriate practitioner. So that gave us some confidence that we are moving in the right direction and that the AI actually is helping and not otherwise. Now, what's the future of healthcare delivery with regards to AI? This is what we think in Harrow is the hub triage. At the moment in Harrow, we're doing it by practice, but I think we need to move to a point where we either by PCN or it's a borough-wide hub triage, where everything is triaged in one place and then they can be sent out to the right healthcare professionals to deal with. Secondly, is coordinating care using multi-professional team, strategic resource planning and allocation. Obviously, once we can see what's coming in, it helps to be able to resource in a more strategic way. And then integration of clinical and triage systems and automatic redirection as part of an integrated care system. One of the things I'd just like to quickly raise here is that Harrow Health is working on a research paper at the moment, and we definitely will welcome academics to participate in publishing a paper, which I believe will be for the general good of everyone and all the key stakeholders. Next slide. So I don't know whether Kanish would like to talk about this.
But there's a YouTube video which basically demonstrates clinic very simply for patients and for practitioners if you want to. And if anyone is interested in helping us produce a paper, well, feel free to email either myself or Samson. We have got the data together about the Harrow experience, and we feel it would be a very valuable research paper. So that's us done. Thank you.
Thank you.
So thank you very much indeed, Kanesh and Samson there. That's fascinating to see real-world application and real-world data coming from AI triage solutions. So thank you very much for sharing that one. We've had a myriad of wonderful questions coming in, so much to see, so much to discuss. Before we get there, I just want to highlight the poll that's been running. Fascinating to see that over 3/4 of our audience believe that AI has the most relevant role in managing triage, perhaps partly due to this presentation, but also only around a quarter of respondents just in this short poll suggest that we may be using AI-based techniques to move patients away from the GP practice. And that's really an interesting piece of information just coming through. And I think I'll take, in preparation for the Q&A, I think now is the right time to launch our second poll so we've got time for the audience to respond. And there we go, that's just been launched now, which is great. So this is great. Thank you very much for the questions coming. We will get to them. We've got one more brief presentation to share first. And I'm prioritizing the questions here beside me so that we've got lots to talk about. Really important concepts coming up. But first, it's my pleasure to introduce again Dr. Thomas Patel Campbell, and he's going to share his experience of artificial intelligence in primary care. Thank you very much, Thomas.
Thanks, Nick, and morning, everybody. So yeah, my name's Thomas. I'm a GP partner with Haxby Group. I'm going to briefly touch on our experience of AI and triage algorithms and our experience of clinic, but I'd echo a lot of what you've already heard from Kanesh. So really the focus of what I'm going to talk about is the barriers and the opportunities for AI in primary care. And also where we see the future lying for such technologies. So Haxby Group, where I'm a partner, is a practice that supports 93,000 patients. We look after patients in 3 main areas, so in York, Scarborough and Hull in the northeast, and we have 13 GP sites. We were the first practice in the UK to implement the clinic system in 2 of our sites, and then this has been rolled out across our whole practice. So what have we learned from our experience? Well, one is to say that patients are willing to engage in this sort of technology. So the graph on the left, you can see that there's increasing uptake of the online platform that we're using to over 4,000 contacts per month. And that continues to increase at the moment. We've also had excellent patient feedback from using the online systems, whether that's for simple administrative queries or the more technical artificial intelligence-driven triage algorithms. There is some of the benefits are around the data that we can get. Some of this is very basic data, so case timings, allowing us to know when urgent cases are landing during the day to allow us to map our workforce to meet that demand on an hour-by-hour basis, which is really helpful in planning when our workforce is available. But echoing what Kanesh was saying about condition types, Haxby Group has always had an MDT approach for the last 10 years or so. We were one of the first practices to have ACPs working alongside our GPs, and we also have ANPs, pharmacists, home visiting paramedics. We have a wide variety of non-GP clinicians working alongside our core group of GPs. And having the condition types has allowed us to be much more nuanced in our workforce planning to recognise the sorts of workforce that we need for each individual population around each of our sites. We can customise the sort of care that we're able to deliver to our populations. And the benefit of this system has been, I determine, augmenting the clinician. So being able to support the clinician or the care navigator with some urgency recommendation from the software, and also for a bit of detail of what the patient background is, allowing us, as Kanesh has said, to make sure that the care is delivered by the right person at the right time, which is very helpful in a practice such as mine, where we are dealing with lots of different professionals with different skill sets. And another important thing I just want to briefly say is about the importance of both the professional user interface and patient user interfaces of these things being as simple and effective as possible. So one of the big things we've had feedback from our clinicians and care navigators is how straightforward it is to interpret what the clinic information is being presented to enable us to make triaging decisions as quickly as possible. So what's the future, barriers and things like that? So I divide these technologies into patient-facing and internal processes. So we have a lot of patients in areas of very significant deprivation, and I'm very mindful of the inverse care law, this suggestion from Julian Tudor Hart almost 3.5 decades ago now, that those who most need medical care are least likely to receive it. And we definitely can see that in our experience in primary care. Those in areas of deprivation are less likely to take up technology such as this. So how do we manage that? We mustn't presume that these patients can't access this technology. We do have some patients who simply aren't able to afford a mobile phone or the data requirement to engage in these technologies sometimes. But actually, sometimes it's simply an education thing. Before COVID, when unfortunately we couldn't do face-to-face drop-in services anymore, we were running drop-ins in all of our surgeries for patients who would like more information about how to use these technologies. And they'd just walk in, they'd have a chat with some of our care navigators, we'd take them through how to use the technology, and they'd leave. And we did find that that did increase uptake. But there's a wider point to recognise that there are some patients who just can't access these digitally, and they either need to be able to access it by telephone or walk-in, or we need to use these technologies to create efficiencies in primary care to allow us to release capacity for more traditional models of medicine, longer appointments for our complex patients, releasing clinicians to do housebound, complex reviews of our patients most in need. And then, so some of that we've talked about is the patient-facing, but actually there's a lot of tools that I'd like to see being used internally in primary care. We have big data sets, and we know that you need these big data sets to progress these artificial intelligence tools. And how can we use that big data set to better the population health of our patients? We've already mentioned about augmenting intelligence rather than artificial intelligence. As Kanesh says, a lot of these technologies aren't mature enough yet to completely automate the process. But how can we help our clinicians both to make triaging decisions, but to recognise in primary care that we deal with a lot of uncertainty and risk? How can we support clinicians to prompt them to potential rare diagnoses that we might not be aware of, and to try and reduce the unknown unknowns of our clinicians, particularly given the wider workforce we're using? But then how can we increase the efficiency and effectiveness of long-term condition monitoring? It's very inefficient in primary care. If you've got a blood pressure problem and you're on some medications, trying to tie together what your average blood pressure is, have you had your renal function checked, how you engage with your professional is very bureaucratic. And actually, there's opportunities here to try and streamline that using the data sets we have, but also to predict those at risk of developing these long-term conditions. Could we be targeting these patients before they develop their hypertension and diabetes and try and intervene sooner to improve the outcomes? And what do we need for this? So we need interoperable systems. This data requires the systems to talk to each other in a universal language. Otherwise, it's very hard to get them working. And I think we need to work at scale. Kanesh has talked about whether they do triage at hub or borough. One of the things we're looking at is actually, do we combine all of the various aspects of urgent care and primary care, 111, primary care and GP surgeries, walk-in centres, A&E? Can we build these solutions to work at that sort of scale to allow a single point of entry for a patient and make sure they get the best outcome? And how do we involve patients in design of these artificial intelligence systems that are patient-facing? If patients don't find them easy, they're not going to use them as effectively as we would want them to. And I think it's really important that we build in patient feedback in the design and implementation of these systems. Thank you very much.
Thomas, that's absolutely fascinating. Thank you very much again for sharing such important real-world evidence of what we're at and the state of the art as well. And it's wonderful how you've described that. This has been very informative. So thank you very much for our presentations. I'm really thrilled now to take this webinar to the next stage, which is our opportunity for questions and discussion. Everyone in the audience has been so interactive, and we're so grateful for this. I'll start off by just looking into this poll. It's probably not surprising by the nature of the presentation and the audience we have today, but around 92% of us listening and active in this webinar today are positive about the role of artificial intelligence in patient flow management, which is a good starting point, because I think we are starting to see, and I'm sure our panel will agree, much more familiarity among clinicians, but of course we've still got a long way to go with artificial intelligence. So I've been carefully tracking the chat, and once again I thank all of our speakers for their great presentations. The chat window has raised some fantastic questions, and I'm trying to categorize them and keep them together. I'd like to start off with one that seems to crop up quite frequently, and this is around the language that we use when using interface forms, for example, AI-based triage. Diana and a couple of others, Sarita as well as a few others, have asked questions around how do we ensure that the language, for example, when describing symptoms, or if people have different backgrounds or different demographics, how can we be sure that when doing AI-based triage, patients are able to still communicate their concerns and their symptoms? I'm happy for perhaps Indra to start with this one, and then we'll hear about the experiences in elsewhere.
Yeah, I mean, I can give a broader overview. I mean, we don't develop specific technology, so I'll leave colleagues on the panel who are working very directly with a specific technology. But just to take this one step broader, it's really important that we involve all end users. So it doesn't matter who is the end user. And so one of the things, so for example, the AI award, we have patient participation groups, but we also look at the impact of those and the inequalities that those technologies might widen and how we can address them if we think that might happen. But on the flip side, really understanding from those end users how best to utilize that technology in whatever the clinical setting it might be, if it's clinical, and operational if it's non-clinical. On the flip side, going back to language, I mean, it's a vitally important point. And one of the things we've looked at, and in fact, we've just done a recent what we call Skunkworks project called Data Lens, So when you're searching for data sets in English, sometimes you know what you're looking. So for example, you might write CCG, Clinical Commissioning Group, and you as a user, when English is something your first language, might be very familiar with that. But in other languages, it might not translate. And so this team have done a really fantastic job of really using almost like a Google search, but from a database perspective. So looking at different data sets and using, so it doesn't matter what language you put it in, it will find that data set for you. So it really applies to whatever the research or the product you're building. So totally agree, really important point, and something we're trying to address from different angles from the centre.
Yeah, it's great to know that your research funding and the activities that you have there at NHS are really taking these considerations on board and looking to make sure that we're developing technology in these directions. I can say from a clinic perspective that because we're operational in a couple of different countries, actually part of my role on the clinical side there is to try and maintain an ability to keep reading age very, very low in all of the services, so that someone has mentioned rightly the concerns around those with learning disabilities, having access with AI-based triage, these really important considerations. And it's something that as a company we consider. I'm curious to know I know this around the issue of access for different demographics is something that I know Thomas has some considerations on. What are your thoughts on this, please, Thomas?
Yeah, so it is a big concern. We know the issue with language is the nuance. It's very hard for a lot of these systems to pick up nuance that a speaker would immediately understand, and that's what I meant about, we need to think differently when we're using this sometimes. Sometimes it's about developing these with a knowledge of the sorts of languages that they're most going to be used by, but sometimes it's about how they're embedded in the local systems. So is it just about having the care navigator who is using something like this to triage a patient to understand the local languages and understand the local challenges that brings along? Or is it actually just about creating efficiencies in triage so you can then have care navigators employed who speak Romanian or Polish and can actually speak to the patients in their native language and then input the information into the software with their care navigator understanding? So I think it does need to be looked at from both sides, but it's definitely an issue because this is one of the things that can embed inequality in the healthcare that we deliver.
I'm fascinated by that, and I can see how that's really important with the diverse demographic across the UK. I'm particularly interested, there's great diversity in Harrow. Samson and Canis, do you have some views on this one?
So yeah, Thomas is absolutely right. It is an issue, it is a concern. But in Harrow, we do have a very multi-ethnic population. And the symptom tree that Clinic has is very simple, to try to keep that reading age down and to make sure that the language is very symptom and patient focused. But there is also the connect side of things. So Clinic also has an option where the patient can ring the surgery. And at the moment, it's our receptionists who traditionally take the phone calls, will actually guide them through and do a clinic query for the patient. So they will actually take the symptoms that the patient has and put it into Clinic and generate into a query. But I think Thomas is right. If you had specialist care coordinators, especially if you're doing this at scale, who could then use their sort of skills and their interpreters, etc., to take that to the next level, then I think that would be very useful as well.
I think that's a key point, and I think what everyone's proposing here, and I know Clinic as well proposed this, is more of a hybrid approach, whereas we're providing at this early stage artificial intelligence which create decision support tools, still very much overseen by the activities of those who already have the skill set required to do triage, required to then provide clinical care. And this ties in with a question from Mary Brown, and asked about the role for advanced practitioners. And I would argue that the more artificial intelligence pathways we could have would actually include more extended roles within primary care especially. And we're also thinking towards the future of where this can be overlapping with secondary care. And perhaps we'll be able to use these sorts of systems to make better use of different pathways within the healthcare system, urgent care centres and so on. So just to respond to Mary's comment, I think there would be an increased uptake among advanced care practitioners, which is good. Tied in with this, we had a question from Yang Zhao, who's asked around age. I think, Samson, you presented some ideas there based on the experience in Harrow.
Yes.
There is It's a misnomer, and I think it's a misnomer that perhaps if you're of a certain age, you're less likely to use certain technologies. And I'm curious to know what your experience in the real world is.
Absolutely. In fact, that's one of the things that really I had to change my mindset about. We had to in Harrow, because when we started, we said, well, from the onset, we need to get the patients involved. So we got some patient leads involved. And if you have a look at the video, obviously, I'm not going to get too much details. One of the patients on that video is over 80 years, over 80 years. And I was just really taken aback. But really, like you rightly said, Nick, there's this kind of thinking that AI is going to disenfranchise some people of certain ages, but that isn't really the case from our experience in Harrow. What I think is very important is the engagement from the onset. There were some perceptions we had to break through, but it became easy for us because we got them involved right from the very beginning. This is what it's all about. This is what we need to do. We had to re-emphasize over and over again, what the intention is and how it's going to benefit the patient. Then we got them involved in clinic. We got them involved they even gave us some suggestions. We have a clinic users forum group. So we took on board their suggestions. We embedded that into the system. They went back to talk to their members. And actually, they have been doing very well. That's our experience in Harrow. And that really has changed, the mindsets of many people in the practices about, those of a certain age.
Well, that's wonderfully refreshing to hear. And as a researcher, I have to say, I think one of the solutions here to some of these issues is very early stage patient, public, stakeholder engagement. And I think that really is the key, because if we try and develop these technologies in isolation, they're really not going to serve their purpose, and they're not going to be properly integrated with the right kind of concerns we're discussing today, with the right demographics. But really encouraging to hear. And I love the comment there from Diana that says over 80 doesn't mean stupid. And we absolutely agree that, whatever your background, we need to make these systems accessible. And the same for the staff on the other end. We need to make sure that they are as user-friendly as possible and that they facilitate the job rather than just add in an extra piece of technology that creates more confusion. There's a couple more questions and ideas coming in. And the great one from Yasmin Morelli, she's asked around cognitive frameworks. I'm curious to know, perhaps go back to Indra, do you feel that by using artificial intelligence, we're forcing clinicians into a certain cognitive framework that may detract from their own traditional abilities in doing the job?
So I'd go back down. I've just had the conversation with a fantastic person from Guy's and St Thomas's Hospital, Harris, who's really kind of outlined this very nicely. People often think artificial intelligence, oh my God, I'll just apply it to a whole care pathway. Break it down, break it down, break it down, break it down. So if you're looking at, for example, image recognition, what image? Head CT, what part of that head CT? Intracranial hemorrhage. Okay, what do you then want to know? So you break it down. And the thing is yes, you are encouraging somebody to look at that, but you're aiding their diagnosis at this current stage. So we call it the human in the loop. There's quite often, nearly always, a human in the loop. We've not got to the stage in clinical medicine where there isn't a human in the loop. That may come in future years, but we're not at that current stage right now. And what I would argue back is we've been doing this for a long time. People talk about AI now, but I'm a doctor. I know there are many other clinicians on the call. We've all been having nudges and, lab results. Really nice one to say, look at a hemoglobin. Is it normal, not normal? Just because a lab has put an underline in it might still be normal for that patient. But as a human, you take all of that down. And does it nudge you into a certain way of thinking? Yes, of course it does. Sometimes, depending on the context. So it's very difficult to answer that in a very broad context. You really got to take it down to what's the problem that particular technology is trying to solve. And then in that context, what is the behavior of the end user?
Yes, I think that's beautifully articulated. And on that topic, for example, I'm aware of certain cases, for example, at the Evelina Hospital in London. They are now using an entirely automated process for bone aging in endocrine disorders in radiology. So the images are taken, and that's an entirely automated process. And that's quite revolutionary, quite groundbreaking. But as you say, that's a very specific use case. And if we start to introduce artificial intelligence in different care pathways, again, we need to be very selective about how and when and why. we introduce them as you've just suggested. And on that topic, there was a question that came in. I think it's important to differentiate. Oh, I've got. Can I?
Sorry to just lose it. Another perspective, just a slightly different perspective, if you like, is that humans have been using technology since the wheel was invented, and as long as we harness it and we're aware of the risks, I think that's the key. That we have to balance it. I remember as a junior doctor a few years ago. That was when people looking at chaos theory to look at prediction of myocardial infarction. And it was a big thing in Manchester at the time. But humans are still deciding whether patients are having heart attacks. Computer hasn't taken that over. And the other perspective I would add is one of my favorite movies, The Matrix. They've never found a matrix to manage the human psyche. And they never will. So we'll always need humans to actually frame the technology.
I think that's wonderfully suggested. And on that topic, it really supports what I was thinking around the fact that we need to also distinguish what types of artificial intelligence. So we're dealing, in flow management, often Bayesian logic, at most a degree of machine learning. But there's a question on that come in from Martin Frenette. He's interested, perhaps for Indra to share, in NHS X, what kind of opportunities there are to develop machine learning algorithms and perhaps even further neural network algorithms within NHSX opportunities and activities. I don't know if there are any schemes around that you could perhaps share with Martin, please.
So it's a broad question. The short answer is yes, we have a number of opportunities. If the question is around more sort of HR and resourcing and sort of applying, we do over time publish applications. We've just hired a number of data scientists and data technologies to develop that. Bear in mind, we are one part of a wider organisation. So whilst we in the AI Lab try and build some technologies through the Skunkworks programme, on the flip side, NHS England also has a very wide analytics team, which again does quite a bit of model building. So lots of opportunities if that's the question being asked.
Yeah, that's great. And I think he's got a bit more detail in this question there in the chat, but that's perfect. Really good to know there's opportunities there. Okay, well, this is good. There's another important topic that comes up frequently, and I think it would be important to share some views on this. This is around some of the ethical considerations, and I feel there are many. One in particular we've highlighted is this potential for inequality of access, and we use the example of those with learning disabilities. Potentially, it would be difficult for them to articulate their concerns. I think we've highlighted how having, as you say, a human involved in the process with decision support tools can really maintain some of the standards we have. But I'm curious to know if the panel wish to share any other ethical considerations around artificial intelligence and on that topic, please.
Well, if I can come in, I suppose I think Indra mentioned it about biases in some of these technology. We have to be a little bit careful about what data sets we're using when we develop these technologies. We're increasingly recognizing that there's bias being built in it. Data out is only good as data in, even in some of these very sophisticated algorithms. And we do need to be careful when we're translating those into populations that it's not been studied on. So if we take a tiny microcosm, if we had built the clinic AI algorithm for our patients in Hull and then tried to use it in Harrow or York, it wouldn't make sense. It would be built around a type of patient expectation and a type of symptom presentation that then fed into certain diagnoses and certain urgencies. I think that is something that we need to be very mindful of, particularly if there are software that we're trying to roll out at a wide scale. If we're looking at a very specific problem in a local area with local data sets, then you can try and manage that. But I do worry about when we're looking at these things at a wider level or in new data sets where it's perhaps unproven.
Yes, I think that's really important. Bad data in, bad data out, really key consideration. Would any other panelists like to add to that?
I think aggregated data sets might be a way forward as well, so that you've got representation from all different groups so that you can actually analyze the data together. But I think Thomas is absolutely right. I absolutely agree with him.
I think one question that's just come in is fascinating, and as an academic clinician on that interface between research and clinical work, I've often found that it can be difficult to convince clinicians to adopt new technologies. A great question's come in from Anjali Hookway. She's asking, how would you suggest convincing clinicians to adopt AI and data-driven technologies in the clinic? Any suggestions, please?
I think this is one of the ways of doing it, what we're doing right now. And, getting the message out, those who have had experience with using it, sharing that with colleagues, sharing that with other clinicians. They can see, that people have actually used AI. They can see the benefits, and it's about getting the message out and changing mindset. Many times it's about mindset. You take, for instance, online consultation as a whole. The COVID situation actually accelerated the usage of online consultation, both from the patient perspective as well as the clinicians, because where they had nowhere else to go, they had to use online consultation. So, and many of the patients we thought wouldn't be able to use the facilities, actually we're using them. So I think one of the ways we can change the mindset, I believe, is to get the word out, to get the message out, have these engagement sessions, talk to colleagues, show them real life grassroots data, and the change is made in the lives of people. And that's one of the ways we can do that.
Yeah, I couldn't agree more, Samson. Beautifully said. Anyone else have any ideas on how we bridge that gap between technology and clinical adoption?
I think if I can come in, so I think it's important to involve as many clinicians and clinician types as possible in this. So I've said, we've got ACPs, ANPs, paramedics. They've all been part of developing the system to understand it, and our non-clinicians. So our care navigators have been involved as well. But it's also, you can't necessarily get input from everybody. We're all busy, and it's that there are simpler things. Just having the output in a straightforward, presentable way. If you're trying to look at something that's a bit impenetrable and you need a 5 or 6 hour education session to actually just understand what's coming out, it's not going to be adopted as well. It has to be easy to use. Patience is important, but it's as easy to use as possible for all the professionals involved.
Yeah, I couldn't agree more, and that's a very good point. And I have to say, this has been a fascinating discussion. I think, Canis, you've got some more thoughts there.
So also, it's important to actually find out the barriers and the issues that the clinicians and the practices have with their current systems, and if those are addressed, and we can remove some of those barriers, make the pathways much more seamless and efficient for them. That's really what they're looking for.
And just one more thing, sorry, in our experience in Harrow, I think change management is so important, because there are quite a number of practices. They wanted to go for AI. Yes, let's go for it. It's good. But they actually took for granted, the amount of change that's going to require. Change in the team, change in the way we do work, the traditional way. And I think we need to always remember that, yes, we need to give some allowance for what that looks like and how we can manage the change management itself, even for those who want to adopt it.
And that's a good point, because as we all know as clinicians, it's extremely difficult to factor in time for these kinds of activities when, of course, we're very much saturated, especially right now with our day job, so to speak, and with the traditional pathways that we know work. So it can be very, very small changes, small increments. And when big changes come along, as you say, there needs to be a lot of time and consideration spent before those changes can be adequately and successfully implemented. Now, I'm very conscious of the time. We've got a couple of minutes just remaining, so I would like to just open up to our panel to say any final thoughts. We'll start with Canis and Samson. Any final thoughts? Do please share.
Just it's been a pleasure to have this conference. I think as the chat and the comments are actually really positive, and it's just very nice to see. That's all I'm going to say. Well,
I'm just going to do a pitch here. We're doing this work on a research paper. So if anyone wants to, join us and, work with us, that would be great. And I'm sure it's going to benefit, everyone in the healthcare setting.
Thank you, Samson and Canis. Yeah, absolutely. Yes, please. That's great. Thomas, how about yourself? Any final thoughts on the themes of today?
Yeah, just to say that I think this is a really exciting area. I think it's going to be challenging to use in primary care because of the uncertainty, and there's more uncertainty and risk in primary care. I know I'm being broad brushstroked, but there's a lot of obvious solutions that have AI options in secondary care and specialist care and imaging and big data sets. But I'm really hopeful that we can look at some of the challenges in primary care. We've got big challenges in primary care, if only with the number of GPs that we've got. That anything like these sorts of systems that can make us more efficient and effective are really important going forwards.
That sounds exciting. I couldn't agree more. And Indra, please, any final thoughts from your perspective?
No, just to say, this is a really broad topic. People quite often talk about AI, multiple different facets to it. So if anyone's keen, do take a look at the NHS website. Lots of content on there. Thanks.
No, wonderfully helpful content there, absolutely. And it's a great focal point for AI education in the healthcare setting. As we said, this is all very new. There's a lot to discuss. There's a lot to consider, many issues. Thank you once again to all of our panel for their excellent expertise today. It's very kind of them to share those with us. And I have to say, the discussion in the chat has been exemplary. The polls have been quite informative. Once again, there are plenty of files and content. Yes, to answer the question that comes up, this is being recorded, so the recording link will be sent out. Again, thank you very much for your attention. On behalf of everyone, have a very nice day.
Thank you. Cheers.